Hi, thank you very much. I've put up this picture to start with, so I'll resume that because I think it's really important to think about who we are sexually and what that means to us. And I think I know the first questions that I ask my clients are what does sex mean to you? What does love mean to you? And what is intimacy to you? And it's quite funny because couples and single people, literally anyone, will come back with an absolute meaning for them. And often that comes from their value system, their culture, their religion, or where that comes for them. And often as couples in a relationship, it's really different. So I find that so interesting. So for the sake of today, I'm just talking about when I say sex and sexuality, what I mean is a mixture of those things. It's a mixture of love for some people. It's a mixture of intimacy for some people. Often in heterosexual relationships, it's quite interesting where often the men will say that intimacy means penetrative sex. I'll try not to use some of my terms. So PIV is my term for penis in vagina. So I'll try to keep it in my normal frame. So looking at this picture, this was a picture that challenged me in the early days. I had a friend in a wheelchair who said to me, I've been asked to do the Gok Wan series. Now, those of you that are old enough might remember the Gok Wan series of Getting Naked. And I thought, if I don't do this, if I don't get naked, what am I saying to myself? And I would always ask my clients to, different things about what parts of their body do they like. And I work so much with body image. So I thought I have to do this. And I was scared. And I think that says so much. You can talk about it, you can do so much, but actually sometimes you've still got that little bit of fear inside. So as you can see me there on the front row, holding on to my rather large knockers and, and keeping myself upright. When God told me to lie on the floor and lift my feet in the air, he was very embarrassed. So I thought I needed to do that for me. And the gentleman sat next to me was kind of like, oh, I don't want my catheter on show. So that was a big challenge for him. And when I was first in the spinal unit, the psychologist said to me, because I said, I don't want to pick my legs up. I hate the way they look. I can't feel my legs, but I can feel my hands. And when I pick my legs up, it feels like holding on to sort of chicken thighs. And so he said to me, okay, I challenge you. I'd like you to put on a pair of hold-up stockings, put the seams on the inside, be careful. And I want you to wear those for a month as often as you feel you can. And within a month, every time I took my clothes off, every time I got into bed, whatever that was, I would look down at these very pretty topped stockings. And I'd say to myself, wow, that's pretty, but sometimes that was unconscious. So instead of telling myself how horrible my legs were for so long, all of a sudden they were okay. And when I went back to see the psychologist, he said, how did you go with the stockings? And, we talked about that for quite a while, about the body image and how that felt. So sometimes we do need to remember that it's the simple things that we can do for ourselves to make us feel better. So this presentation today is a quickie. We can't talk about everything possible in sexuality. There is so much, because sexuality is who we are. It's about how feminine we feel. And obviously today's talk is to girls, women, and it's aimed at girls and women and girls and women with spinal cord injury especially, and moving forward. What do we feel? How do we feel it? To normalise it. And what questions might we want to ask somebody? And also to the healthcare professionals out there, sort of really looking at what questions do you want to ask your client or patient? Because often when we as professionals, whether that be whatever profession dealing with spinal cord injury, if we're not going to start the conversation, sometimes it gets left behind. And I'll talk about why for women in a moment. So it is a quick session, and that's why there is opportunity for questions. And you can also contact me directly, so we can send those details out directly. So I'm at Michelle Donald, PST, at btinternet.com. If that could go in the questions, that would be in the questions and answers, so people can copy it and keep it. I'm happy for you to send me questions over, because I am well aware that sometimes it doesn't feel great to actually write that down, or that it takes a while. Mainly I see outpatients, so I see inpatients initially for questions, and then outpatients 2 to 3 years often down the line when they start to go, okay, I've got a question now, or sex isn't like it used to be and I don't know what to do differently. So it is a quickie. Okay. So who am I? And I was introduced then by Rhiannon, but yes, I work in lots of different areas. I was paralysed in 1996, so it's my 25th anniversary in July. And it was one of the things that often doesn't get spoken about in spinal units, and especially through COVID, we know this has been really difficult for spinal units to manage. So we know there's that gap out there. So it's brilliant that this area has been taken on. Okay, so how do we know women need help? So in the spinal units, men will go, okay, I'm not getting my erection, and this is happening and that's happening, and that's how they open up the conversation. But actually for women, it's really hard for our healthcare professionals, most of them, because they don't always get the training to start that conversation. It's hard for them to actually ask that question. You know, walking up to somebody that they don't know, that's maybe of a different culture, or maybe 20 years older than them, or 20 years younger than them, the age is different as well. It's hard for them to actually say the words. But when I think back to when I was in the spinal unit, it was really important. I went home on weekend leave. And on that weekend leave, my partner, I'd been with my partner for 4 months. I was in a heterosexual relationship. I'd been with my partner for 4 months at that point, and sex had been a big part of our relationship before our injury. And I call it our injury because we were together. And we didn't talk about it, and nobody at the spinal centre spoke about it to me. And I went home on weekend leave, terrified, absolutely terrified. What do I do? How do I, my body image was so different. I was a racing cyclist before, I was very vain. And I was absolutely terrified. So I laid on the floor and thought, well, surely I'm not the one who can get on top, but don't know what to do. I might break something. And he was terrified because he thought, if I lie on top of her, what if I hurt her? And I hear this all the time in every relationship, in any couple relationship. What if I hurt my partner? So he was terrified. How he got an erection, I have absolutely no idea, with all that adrenaline running through his system. And we tried to have penetrative sex, and I couldn't feel it. Now, I'm T12 complete, so of course I couldn't feel it, but I hadn't kind of figured that out. I thought if something goes inside me, maybe. I had an indwelling catheter on. That indwelling catheter, I was terrified. I was terrified about where it sat in my body, if it would become dislodged. I didn't feel sexy, this bag of wee around my leg. I didn't know if I was ever going to lose that at that time. I didn't know if that was going to be a fixture for me, and neither did my partner. He laid on top of me, and all of a sudden I let out the most amazing amount of wind. And I'm thinking, oh my God, how unsexy do I feel right now? My tummy had changed, my legs had changed. And he stopped and said, I'm all the way in. And he looked at me, and I just burst into tears. And so did he. And because nobody had spoken to us, our fears were so high. And actually, I didn't know whether I would lubricate or not. And I'll come on to that in a second. So for women, it's really difficult to open up that conversation. But I urge you as health professionals and as patients or clients just to bring up that subject with everybody, not everybody, but with anybody that's your healthcare professional that you need answers from, that you think can help you. Because if you ask the question, it will be referred on, and you will get an answer. So we've nothing on the outside to show how we're going to get fixed. So, and I always say this, it's okay for men to go, okay, let me have a PDE5 inhibitor, a Viagra or something like that to make me hard, if that's possible for the man. But actually what it doesn't do is it doesn't make you feel it anymore. It doesn't allow you to feel that ejaculation any better, but it makes it hard for longer. So that's for that PIV, for that penis in vagina sex, or penis in wherever it needs to be sex. So I think that is the hardest point, that actually we often say, well, it's all right for men. But actually, when we think about it, it doesn't change that much, if you will. So for women, and I'll talk about the vagus nerve in a moment, it's really important. There is so much we can do to enhance our sex lives, no matter what level of injury. So in hospital, we're going through so much. We're going through that change in body image. We're going through that kind of loss of identity. So I was saying I lost my femininity. That was really hard. I was like, oh my word, that chair's huge. Or, you know, I talk to people that are walking and really struggling with the way that they walk and how that looks to other people. So, and being in bigger chairs and how that feels. So we kind of have this loss of identity for a while, where we wear baggy clothes and it feels really different for us. And then we leave, or we keep a bit of our identity in hospital. And then all of a sudden we can go back to wearing nearly what we want. So I've got 3 foot plates. My 3 foot plates for all my different types of high heels. I'm not losing my femininity. I still wear my dresses. I still wear my long boots. But it did take a while to actually find a different type of fashion that worked for me, that enabled me still to feel feminine and sexy. So our bodies kind of become public property. And again, if we do need a PA or a carer later on, I'll talk about kind of the issues that can go with that, and how we might talk about that. I just remember, you know, Monday, Wednesday, Friday on bowel day, and how awful it used to feel, until I got used to that. And everyday tasks were taking a bit longer, and how tired. The tiredness with the different drugs we're on, and it's so important to keep checking with your GP or your consultant. Why am I on this drug? What's it for? Is there a better drug I can take? Because all the drugs that we're on change, especially if it's for, especially if it's for pain. If you're on anything that's for pain or spasms, that will change the way the sensation of your skin feels. Now, I'm not saying under any circumstance come off those drugs. What I'm saying is just keep checking why you're on them. Sometimes 2 or 3 years down the line, things change in our body gets used to the hypersensitivity. I remember being in hospital and the hypersensitivity was horrendous. And I thought, wow, I couldn't even have anyone touch my tummy. And then 2 or 3 years down the line, in fact, it was quicker than that, I was able to feel a different sensation there. And I came off the drugs for the hypersensitivity, and then the sensation had definitely changed. So that's why I would say just check that all the time. Now, I love my little car, because often I think we need to sort of be, in the beginning, we say, oh, well, and we compare ourselves to what we were like before. So often we feel like, actually, before it was automatic, just jumped in and drive. There were obstacles, I just got around them. It's okay if you don't know where you're heading. You don't have to be too scared about that. You just set off and go. The bodywork, whoa, so much more reliable. You fuel up and go. You'd have the occasional dent, but you reshaped. And now, sometimes it feels initially, because we compare ourselves to our previous selves, if you will,
We seem to have lost Michelle. So if everyone can just bear with us, I think she'll probably try and log back on in a minute. I think she's probably just lost her internet connection, the joys of Zoom. Bear with us, and I think she's joining us now. Michelle, sorry, we'd lost you for a second. I think we missed the last 30 seconds of what you were saying. Thank you.
I've just hooked up to my 4G in case it's my internet playing up. So
Okay.
I'll just get that back on.
Thank you.
Okay. So the engines are less reliable and not automatic. Unpredictable things can happen. I can get hot and cold and spasm, especially when we hit our menopause as well, which is just happening to me. That's a whole other talk about sexuality and HRT, if that's the chosen route. Brakes don't work so well. Can't tell one noise from another. I'm better parked up or not. Okay. So I want you to think about where you are right now and think about, because kind of this was me in the spinal unit thinking, you know, I'm in chains here and I don't know what to do. And it's for us to start breaking those chains, to start asking the questions, to start practicing. We practice bowels and bladder every day because our life depends on it. But actually, with sexuality or sex or penetrative sex, we don't practice that all the time. And often, and I was speaking to a couple yesterday, and the gentleman had been out of his spinal unit for 8 months, a young couple, and they'd had an amazing sex life before. They'd had a very active and good sex life, as they describe it, but they still hadn't started, a heterosexual couple, they still hadn't started to have a sex life because both of them were too scared. So we're too scared to start doing our bowels and bladder, but we have no choice. So it's about how we start that process. And again, I'm going to talk about that in a second. And how we can get rid of those chains, actually. Sorry. So I'm just going to move some things and I can actually see my screen. All right. What's the point? I can't feel it. This is the biggest question I get asked, and usually early on. So in psychosexual therapy, we look at a new body and the different ways that it responds. We unravel the meaning behind what are the sexual difficulties, because sometimes they were there before and they continue or get worse after the spinal cord injury, and because we don't know how to manage them. We look to overcome them in a creative way, a new way, and be together intimately. So I give people tasks to do. So we'll talk in the session, and then people will go away and do their tasks. And then in the next session, I'll take the feedback from those tasks and I'll set them new tasks. Now, the original tasks start with getting everybody on a level playing field. So for people to be, so to look at initiation, to look at touch, to look at what hurts, to look at positioning, even if that's, you know, staying in your chair if you're in a higher level chair, if you will. You know, a couple that I was working with, again, not long ago, we talked about, and she was so excited. He was in a chair, really a high level injury, and she couldn't get to him for his chair. And she said, we went away and really thought about how we could be imaginative. And she said, he loved, so they took the side or the back off the chair for this encounter. And she said she kind of just put herself and her body and her naked top of her body against the back of his neck, and he felt the warmth. And the chemicals that go when we do that, when we hug, when we hold, when we have that absolute touch, or, you know, you've got your serotonin, your dopamine, your oxytocin, they're so powerful and they allow us to relax. So a lot of clients in sex therapy have little idea what they might enjoy sexually, because the desire to be seen as normal overwhelm any curiosity about their own unique, how their own unique sexuality might work. So that's really important. You've got to be ready to start the work. If you're going to carry on having sex like you did before, it's a very, very different game. So we know health professionals are scared of asking the questions. And we know these are the main questions that people ask. Is my body going to do what it needs for sex to occur? Will my partner be turned off by my naked body? And another question there is, how do you feel about your naked body? How can I make sure sex is safe without ruining the moment? And again, when I say sex, I mean the whole intimacy, touching, feeling, being with someone. It might be a new encounter, or it might be a partner that you've had for a long time. Will I orgasm too quickly, too slowly, or not at all? How will I know what to do to turn the other person on? And often that's because bodies are not moving in the same way, or they're slightly unreliable because you haven't got used to what causes the spasms and when and how to minimize them. How to meet a partner and sustain a relationship. How to get sexual satisfaction from your own sexual experience. So if you did do your own self-focus before, how does that now work for you? And how does that need to change to work for you? Often I talk to women that go back to their own vibratory routine. And actually to put that anywhere near the clitoris is too strong, or they don't feel too much. So I recommend to start with a vibrator, to put it around the level of the injury or just above it, and let the vibration flow through the body and see where you pick up that vibration. And I'll talk about nipple sensation if you have it in a moment. And is having a child possible, and how? Now that is something that does get spoken about within our rehab more often than not. What do people say? I won't go through all these, but I'll pick out a few. I hate feeling that I'm being not raped, but used, just lying there. I haven't accepted what I'm like. I don't like looking in the mirror. I don't like having photos taken, and I've gained a lot of weight. It's hard because there's carers in the house, and knowing that somebody else might hear and be involved, and you can hear people walking up and down the corridor, and that makes it really awkward. And a lot of us know how that feels with children. And we know how that feels if our parents are living in the same house as us. I'm never going to have a boyfriend. A lot of people say, how am I going to meet someone? I'm ugly and my body's different. I don't like it. And I don't want to show it to anyone else. That's it for me. What we have to remember is what's happening right now isn't always going to happen. And it's about taking those baby steps. Sexuality, we've talked about this a little bit. It's so many things to so many people. What else do we need to look out for? So we need to look out for, because our bodies have changed so much, how are we going to maintain our weight? Our bodies are not using the same amount of energy that they were using before. So it's really important to get that. I ended up I was 7 stone 10, and I ended up being 11 stone 2 years after my injury. I was devastated. I got back down to 9.5 stone, between 9 and 9.5 stone. Was only 5'3". I'm only 5'3". I really had to get that under control. And I think that was my first challenge to myself. Do we have diabetes? How do we manage it? High blood pressure. Do I drink too much? Do I smoke too much? What medications am I on, and how do I change those, and how much anxiety is there? So these are all things that affect our sexuality. Different things to do with blood flow, to do with diabetes and high blood pressure, different things to do with touch, to do with drinking and smoking, and how our body feels sensations. So they're all really important. Consider the impact of culture and religion. So when I'm working with people, often it's about what is it for them. There was this lady I was working with who said, my husband absolutely will not want to stay married to me now. I can't have his children. And that's really important in our culture. And she was already in the spinal unit getting ready to end that relationship, just to save him doing that. So a lot of work was done with that, with the psychologist and myself, to look at what that meant to her. So it has a big impact on us, and we need to really think about how that affects our lives. But sex fulfills so many needs, and it's really important to really think about it and think about the affection that goes with sex. So many times I talk to people and they'll say, I don't, if my partner touches me, well, that normally, that used to mean if he touches me in a certain way, well, that means we're going to have sex. So I've stopped him touching me in that way because I don't want to have sex. And then so quickly the affection disappears as well as the sex. So it's really about remembering how good sex can be, or how good the affection can be without the sex, if that's what you want. So the importance of feeling wanted, accepted, loved and whole. And on that, really thinking about, I remember trying to push my partner away. Why do you want to be with me? Why do you not want to go and find another woman that's standing up and walking around? And all of my insecurities came into that. And he said to me simply, I didn't fall in love with your legs. And I didn't believe him for a very, very long time. And I tested him to the hilt. So we have to be careful of that. And I do see that all the time, testing partners. You know what? Believe them when they tell you they love you. Work with that. So to console and comfort, that need for touch, physical closeness, emotional bonding, again, those chemicals that fire. And we know it's linked to happiness and satisfaction in the relationship. We are talking about close, happy, consensual relationships. It can release tension. Yes, it can get rid of your headache. So if you do have a headache, actually having sex can actually get rid of that because of the dopamine release, the oxytocin release, etc. It relaxes us physically and emotionally because of all the release of the chemicals, distracts us from pain. It improves our overall sense of self-esteem, and it increases our sense of self, our femininity. It helps us cope with anger, again, because of that chemical release. And the reason I put stick to life in there is because I work in oncology sometimes. And when we talk about people having sex at the end of life and how important that can be to some people. So let's look at what's affected. How is sexual function affected and what can be done about it? So the first people that I came across in my studies were Masters and Johnson. You may have heard of them or not. And they were the first people to really study on an academic level sexuality. And I love this quote: a stiff penis does not make a solid relationship, nor does a wet vagina. Absence of sensation does not mean absence of feeling. Inability to move does not mean inability to please. Inability to perform does not mean inability to enjoy. And loss of genitals does not mean loss of sexuality. We can take that last one, as a lot of people say they've lost their genitals because they don't feel them. And some people maybe that have been on the front line have actually lost their genitals. So what interrupts us as women initially? We've talked about fatigue, the desire, the menstruation, and getting that right. So important to speak to your healthcare team about your menstruation. And actually going through the menopause and what will help. I've just been to see gynecology, and I'm now on HRT patches, and I'm on testosterone, which is not licensed for women. But if you do speak to your gynecologist, it can be explored. I can also add some links to looking at that and why, and looking at other details about the menopause and how it affects us sexually. Our hypersensitivity, our bowels and bladder, again, so important to get those right. If our bowels and bladder don't feel right to us, it stops us from participating in different sexual acts and oral sex. Lubrication. So if we're touched between around the areas, and this is different, so many people, because we know our injuries are so different, but between T11 and L1, L2, if you feel pinprick sensations around those areas, you may still be able to lubricate, because the messages may still be getting through from your brain to enable that lubrication. So I know I lubricate well. I didn't know that until I had my injury, but I would recommend lubrication all the time. So there's two products I recommend. Yes is an oil-based and a water-based lubricant. There's a YouTube video that I've put together with some expert colleagues on different types of lubrication, because there are so many different types of lubrication. So there's one called Yes Yes, and there's another one called Pure, Pjur, and they're organic, and there's another one called Silk. So make sure you don't get, you know, a lot of the oil-based ones are not to be used at all with condoms. They will destroy the condom or sex toys, because they'll destroy the silicone in them. So it's looking at other types, like silicone ones are really slippy and water ones are great, but sometimes you need to use one of those little plant sprayers to get them back to life. So it's really looking at that. And then obviously the constraints of positioning. And again, I know some websites for the positioning. A gentleman, a sexologist in America called Mitchell Tepper, has some fully clothed people of different levels of spinal cord injury getting into positions. So that's really interesting for physios to look at, to be able to instruct people about how they might get on their knees if they can, and what different positions that some people may be able to get into. So that's important. So again, that depends on touch as to whether or not you can lubricate. Sexual exploration with or without a partner helps identify methods of stimulation. Again, I'll go back to the vagus nerve in a moment. Couples can progress from simple tasks, and this is what I do in my sessions. So we talk about non-genital touch to start with. Take all the pressure off. It's just about exploration of your bodies. Now, many women with spinal cord injury often think that because they haven't orgasmed at a point where they used to, that they won't orgasm again. And actually what we found is lengthier foreplay can often enable this. But what we do is look at which areas of the body we can stimulate. So that might be the ears, the back of the neck. If you've got more sensation, the nipples are so important. Even if nipple stimulation before felt too much, it's about, I ask people to really start to think about how they touch their nipples, what they touch it with. Often if we touch with the point of something, like the end of our finger or the end of our tongue, that can be too much. So it's about having a warm sensation on the breast. So the middle of the hand, and putting it over the nipple and then moving that around quite slowly. And often people who do feel their nipple sensation report through their vagus nerve, this is what will cause it, it allows them to actually feel like they're feeling their genitals. So so many people report to me, and I know this is a fact for myself, that doing that, sometimes people have to open their eyes to actually know that their genitals are not being touched. It's just coming straight through their nipples. So even when you don't feel your genitals, I ask people to really start to explore that area for themselves. Sometimes it comes from the ear, skin surface, and under the arms, which is quite strange. So it's really looking at what works for you, but the vagus nerve does help with the nipple stimulation. Some individuals find the skin surface around the neurological level has heightened. So initially you might find it painful, but then some people really like it because it heightens their sexual response. So it's about really looking at other areas of your body. So it's about what fires off in your brain. And those chemicals that I keep talking about. But I also think it's really important to know where everything is. And you'd be surprised that so many people are confused about where everything is. And as a 27-year-old in the spinal center, I was confused about where everything was. So I never take it for granted. So the clitoris sits right in between where the labia open. Some people have got larger internal labia, and some people smaller. So we all look so different. And I think people forget that. Men see each other in the changing rooms all the time. They kind of have an idea about what other men's genitals look like. And women, we don't sometimes. It depends again on our culture and how we've been brought up. So I want you to bear with me through these slides. I find them so important. This is still happening in your body as a spinal injured woman. So locate the bladder, locate the uterus, locate the vagina and how the vagina makes its way up to the uterus, the cervix. So if you keep looking at that as I flick through them, I'll flick through them quickly and then I'll come back. Look at what happens in the process of feeling aroused. So if you look at something and you get aroused through the vagal system, even if you're spinally injured, this will still be happening internally. So kind of we get away with it. Men often have a lot of pressure on them because they have an erection or they don't have an erection. Now this is our secret internal erection that nobody knows about, only us. So every 90 minutes, well, we don't know it's happening. Every 90 minutes during sleep, you will lubricate. Every 90 minutes during sleep, a healthy male will get an erection. And it's just our reflexes system, if your reflex is still intact, it's our reflexes system of keeping our genitals healthy. So important. So I've got a time check. Okay. So it's really important that happens, that we kind of really know what's going on for us and our bodies are keeping us healthy. So I'll flick through these. We can see the uterus elevating. We can see there that the vagina expands. Can you see how much further? Look at that. And it lengthens. If lubrication is going to happen, it will happen. And then we have that fully elevated uterus there. Look at that tension effect of the cervix and that full expansion. So if women are looking to have children and they're doing it via different methods. So sometimes if it's two spinally injured people and they're extracting the semen from the guy and then putting it internally into them, it's really important that the woman is lubricated or is aroused, so that there's a better chance, as you can see there. And in the next slide, the semen has somewhere to go and the semen has somewhere to stay. If you try to put semen in there, it will just come quite quickly out. So here we have that tenting effect. We have an area for the seminal pool, and then the uterus can descend, the cervix dips. So we have more chance of enabling a pregnancy at that point. One thing I want to note is the vagina, the outer third, returns quite quickly to normal. I'll show back to about here. And the inner 2/3 will take quite a lot longer. So the bottom part, so where you see the vagina there, will close up quite quickly, but internally you will be staying like this, which means that if you haven't orgasmed at that point, there is every likelihood that you could at a later stage. Now, don't feel that you're discounted because you have a higher level injury. So it's about the nipple stimulation, the ear stimulation, the neck stimulation. There's so much that women can do to enable that to move forward. What do we think this is? I love this picture. That is your clitoris. So you can see there at the front, there's the glands. That's the bit that you might see. And then the bit at the bottom is all your labia and the blood vessels. And then internally, and you'll be surprised if you see a picture of a male shaft, it looks quite similar to that, or all your smooth muscle cells internal. So your clitoris stretches all the way back to your perineal sponge. And that's why I talk about it being really important when you can use like vibrators to enable stimulation on different parts of your body, because the stimulus could come from anywhere. So let me explain that in more detail. So you can see this is the clitoris on an MRI scan. So it goes all the way under your labia. So if you've got, say, a finger inside your vaginal opening and you're pulling against what is classed as the G-spot, some people say that exists for them and some people say it doesn't. If you've got a finger internally in there, or a partner's finger or someone that can tell you, you can pull against the front wall, so pulling towards the stomach from inside, and there'll be some ridges there, and those ridges can be classed as the G-spot. If you push on those ridges, sometimes that enables the skin gland to get rid of some liquid. So sometimes some lower level injury women will think they've wet the bed. And this has been reported more so with lower level injuries, but I think that's because more lower level injuries women will try that for themselves. So I think it's just not reported in higher level injuries because it's kind of not been played with as much, not been experimented with. So my science in my own head my hypothesis would be that it would be the same for most women. And what happens is the skin gland can empty. So this is like, I don't know if you've heard of the same squirting. Liquid will be let out at that point. And often that liquid isn't coming from the bladder, more often than not at all. It is a different type of liquid. So watch out for that and see if, what type of liquid that might be. And I also ask people to try themselves, to explore what it feels like on the inside of your own vagina and how comfortable or uncomfortable it is. I talk to people, sometimes we just do 2 or 3 sessions on this, feeling comfortable or not, taking feedback. When you do psychosexual therapy, you don't necessarily have to do a whole thing. It's up to you how much you want to do. So we talked about the sexual hormones, which is really important, our serotonin, our dopamine, and our oxytocin. I'll recommend a book at the end that'll give you quite a lot of detail about that and how important it is. And for some people, they might think that what they're feeling right now, and I alluded to this earlier, might last forever. Take those tiny steps. Successful adjustment. How do we stop staying where we are, I suppose? The ability of the person to resolve the emotional issues of the SCI. And that's why I say I tend to see people 2 or 3 years down the line, once they've kind of got their life back into some sort of normality, got home, etc. I talk to people about the beds that they go home in. If they go home in a hospital bed, actually that might not be forever. That's about space, it's about time, it's about getting another bed that you can attach to it. I spoke to a little old man once and he said, nobody's considered my affection with my wife. Nobody's asked me about my affection. He said, and I go to bed at night, the carers come in and I just feel like I've been separated from her. And we used to sit in bed in the morning and have a cup of tea. And that was our sensual time, our touching time, our affection time, our holding hands time, when we talk to each other. So think for yourselves about how carers interrupt your routine, how family interrupt certain things, your own boundaries, how beds can interrupt that. And sometimes we're knowing that we might have to be downstairs for a while until things change, but actually not making that last longer than it has to if we want to be sharing a bed with our partner. Sometimes the system can get in the way and we have to challenge it. The extent the individual can value their new abilities and let go of those old ones, communication is absolutely a must, and that's so difficult. I'm working with a couple right now actually where the communication comes from. She'll send emails to me describing how she feels, but always copy her partner in, and her partner can then read those emails. She said, if I'm going to send them directly to my partner, then it will be worded different, and I need him to know so that his defenses don't go up. So that's a really interesting bit of work that we've been doing recently. Body mapping, really important, and a sense of fun. Why do I do body mapping? And we do this before I start the process quite often with lots of people. So the emphasis of it is intimacy and differences in sensuality. The process helps rediscover your body, but theirs. Often we've been without our partners for months, or it's a new partner. So it's like playing. The exercise enables people to really better understand how they've changed and get back in touch with their partner. Because many partners are really tentative about touching and they're confused where is sensitive and where is painful. I remember saying to my partner, oh my God, don't touch me there, it hurts so much. 3 years later, it was such a different feeling. And he said, well, I've never touched you there because you told me it hurt. So that was our communication not working that well. And body mapping, so it does help with communication, and it can be fun. So this is something you can start yourself, start to play. If sex is about play, it's more fun, because what happens is we can often get into patterns where they can be unhelpful. So one of us stops initiating, and if we stop initiating, then our partner stops initiating. So I often work with scheduling. And that sounds so unsexy, but for so many people it works so well. We have to think about what's happening for our partners if we have partners. You know, we've been in the spinal unit, we've been fed spinal cord injury 24/7. They haven't. They've been running the house, they've been doing things differently. They might have had to switch roles between care provider and lover, or they might have had to take on, you know, looking after the children and not going to work, or because of COVID, things might have changed even more differently. Their loss of libido, and we can't always put that down to us. Again, a couple I work with, you know, they'd gone into separate rooms because she needed to keep turning and it kept waking him up, and she was still doing her catheter on the bed, and because that was actually easier in their unchanged home. And when they moved house, nobody asked if they needed to go back to the same bedroom, because both of them were scared to ask that question about actually. And for him, he was like, actually, I wanted to come back into the bedroom for so long, but I was just scared that if I touched you during the night, it would hurt. And she said, I was scared because peeing on the bed is really not sexy, and I didn't want you to see me doing that. But he, you know, I don't do that anymore and I feel okay about it. But if she did, having that conversation about how that works, that was such a big part of them getting back together. And this was a quote. It never occurred to me that it was her illness that was making her tired. I thought it was me. I wasn't doing enough for her. It's hard when you can't give someone pleasure you used to give them. I feel I can't talk to her about my problems. And when I have got things to complain about, and when she's paralyzed, it took us such a long time to recognize that this was causing a big gap between us. Communication. 3's a crowd. I know how we're short on time now. So 3's a crowd. It's complicated enough. Boundaries, communication with your PAs. That's a whole other workshop. The impact of the carer on the relationship. So the need for sexual expression is never lost as a result of the injury, and every person is a sexual being. Every person has the right to sexual expression. It's up to each person to discover the kind of sexual expression that works for them and the best way to achieve it. Thank you.
Okay. Great, thank you very much, Michelle, for that very informative presentation. I'm sure all of our attendees found it very helpful. We have had a couple of questions put to us, so I'm just going to ask you. One of the participants asks, where can I find the pictures of clothed people for sexual positions, please?
Okay, look for Mitchell Tepper, sexologist. I don't know the exact website, but it's Mitchell. Let me just write it down or I can't spell it. Mitchell. Tepper is Tepper.
Great, thank you. And another one that we've had is, can you get referred by a GP to a specialist? And if so, who should you ask for?
Getting a referral from a GP to a psychosexual therapist is quite difficult. A lot of people don't support it. You can get them through oncology, and you can get them through gynecology, but a lot of the time for spinal cord injury, it is a private affair unless your spinal center has acknowledged it and has somebody at the centre. I mean, at the centres, you've always got your function. You've always got people that work with function, and they're pretty amazing. They have so much knowledge. So I would use the people at your spinal centre, so that work with the function side of things, or has to be referred out to the gynecologist that works with, and often they'll have detailed knowledge. But actually the psychosexual, see the counsellor, often there are counsellors there and they may open up that conversation for you. Or alternatively, go to COSRAT, the College of Sex and Relationship Therapists, and you can find a sex therapist in your local area. You'll expect to pay between £60 to £120 an hour for a session. I would always say to anyone that's going through a compensation claim, get this put on your claim. It's a really important part, and often it gets missed out.
Okay. Someone else has asked, do you personally see patients outside of your spinal centre? And I think it's fair to say, without promoting your services too much, but you do see people on a private basis.
Yeah, but at the moment it is all via Zoom, and I can't see that changing. It works really well in that people don't have to leave their homes and they don't have the access issues. And me as well, don't have to get into people's homes, and it's safe.
Are there other, and I was just going to ask, are there other support groups out there, Michelle? So if people can't afford to go down the private route, I was just thinking, if they go looking on places like Facebook or things, are there other groups where you can tap into like-minded people?
There's a company called Enhance the UK. Enhance the UK have a love lounge, they call it, which is fabulous. And you can ask questions in the love lounge about anything. And they often, if it's a question they can't answer, they'll send it to me and we'll have a chat about it and they'll go back to the client. So that's a free service. Enhance the UK are amazing, and the people that work there are incredible. So yeah, I would always recommend Enhance the UK. Backup have put quite a lot of information on there, which I update regularly when it changes. So they've got a sexuality support page, the Backup Trust. Just trying to think of other things that are just specialist, if you will. There are 3 psychosexual therapists that specialise with spinal cord injury. So there's myself, there's another lady called Sue Lennon. Sue Lennon actually lives in France, but does all her work over here, so, as in on Zoom. So if you just put in Sue Lennon and it will, psychosexual therapist, and she will come up. She's also on the COSRAT website. There's another lady called Sue Newsom. Sue Newsom works with all neurological and disability. She is just an incredible lady, does a lot of work with Tantra as well, so tantric sex. And surrogates, really interesting work on surrogacy. And how, because at the moment as sex therapists in the UK, we're not allowed to work with surrogates. So a surrogate being somebody, if somebody's single and they want to practice being sexual, a surrogate worker is someone that's not a sex worker, it's someone that will work with them, but through touch, to enable how do we have conversations, does our body move, etc. So we're really working with trying to change that in the UK at the moment. So that's Sue Lennon, Sue Newsom, and there's a lady called Ruth Hazelton. She's based in Brighton, and she can be found on the COSRAT website as well. So they're the main 4 of us that actually work with spinal cord injury very confidently.
Okay, and I think there's another question that someone's asked, which is, I had a patient with SCI that was a virgin and was concerned about starting sexual activity post-injury. What advice can I give to her?
Okay, got so much that I can send to you if you want to ask for some information. Really, that's about permission. It's about just asking the questions that maybe delving a little bit further. What do you need to know? What comes to mind to start with? Asking the questions about the bladder. All I needed to know when I started was the catheter sits inside my body. Will it be dislodged? I didn't even need to ask the question. She didn't have to ask me the question about sex, but actually that would be about limited information. So My information will be, look up the PLISSIT model, PLISSIT, and that's about how professionals can work with sexuality with their patients. So it's permission first, then limited information, then specific suggestions, and then refer out to intensive therapy if need be. So look up the PLISSIT model. There's some great YouTube videos on the PLISSIT model. Something came to mind and that's gone, my menopause. We'll come back possibly. Okay, so hopefully that helps, and really talk about the lubrication, but a lot of the times that's about how she's meeting people. You know, on the enhanced site there's some detail about devotees, so we need to sort of sometimes be careful, know that we're working with, see if she's got friends that she can talk to that can sort of, if she's not seeing, so say for instance she starts a new relationship, what did they think about her partner, etc, etc. Have a check-in, because this is a lot about psychological responses. It's about finding a partner. It's about, you know, her fears might not be about specifically sex. The question she might be asking is, how do I find a partner who'll find me attractive? What is that for me? So there's so many different ways you can go with that, and it's about what she actually really wants to know.
Okay, great, thank you. And I think someone else has asked, what does COSRAP stand for?
COSRAP, sorry, the College of Sex and Relationship Therapists.
Perfect, thank you. I
So,
think we've just posted a link to that as well. And I suppose one final question that we've had is, what's the best piece of advice that you would give, or that you have learnt over the course of your either experience as being a psychotherapist or just through your injury yourself, that you would want to pass on to others?
Ask the questions. I know that sounds really simple, and communicate with your partner. And I know, well, it doesn't sound simple because we know those things are not, but also don't be scared to contact a professional. If I'd spoken to a professional early on, it would have been so powerful, to be able to ask the questions that I wanted, because all our questions are different. The biggest piece of actual sexual information for me is, gosh, even I find sometimes really difficult to just open that up, is touch and sensation. Relaxation is the biggest thing for people. So to relax and allow somebody to touch your body or explore your own self. I was talking about before, putting a finger into your vagina, know your vagina, know what it looks like. So if there are any difficulties or any issues, and I know, you know, I never used to look at my vagina once a month, and now I have to catheterize 7 or 8 times a day. I don't have any choice. I do use a mirror for that, because I just find that helpful, just to completely keep an eye on what's going on down there, what's coming out, what's my discharge like. Know your vagina, but also know your lubricants. Check yourself out, go inside there, see what it feels like. Somebody said to me the other day, it feels like soft white clouds. I was like, okay. So know your body. And also, this is a brilliant book. It's not for spinal cord injury, it's not necessarily for spinal cord injury, but it's fantastic. It's called Mind the Gap. I know it's back to front. Mind the Gap, and it's Dr. Karen Gurney. The Truth About Desire. I can't read that back to front. The Truth About Desire and How to Future-Proof Your Sex Life. It's really interesting. She does little quizzes at the end. And actually what something like this can do is enable you to touch your partner. You can do the quizzes with a partner, or even if it's a new relationship, you might go, and now we can go out to dinner nearly. You might be able to go out to dinner and just have kind of some of these conversations on the first date, not necessarily sexual ones, but asking some of the questions that are in the book. So sorry, that was a very long-winded answer.
No, great, thank you. I think that's all the questions that we've had, and once again I just want to thank you so much for your informative talk, which I can see from the comments that we've had, lots of panelists have found and attendees have found really helpful. So thank you once again for joining us today and sharing your knowledge and experience with us. Thank you to all our attendees, and we look forward to you joining us next week for our seminar on parenting with a spinal cord injury. Thank you. Bye-bye.
Thank you. Bye.
Bye, Michelle.
Bye-bye.
Thank you.